So everyone, today we're going to go into diabetes diet trends. We're going to separate some of the evidence from misconception, do a little bit of myth busting, if you will. I will say that all of this is, I will state if it's my opinion, but otherwise this is all from reviews, from meta-analyses, from systematic reviews. So don't shoot the messenger, if you will. Okay. It's like this is really just this is the actual science. As I said before, I am from Humphreys Diabetes Center, and I've been a CDCES for almost 10 years now. So, really enjoying this and very happy to present today. Next slide, please. So, these are our learning objectives. I've already basically stated everything, and I will kind of wrap around to what can we learn about diabetes nutrition goals. Next slide, please. So, why do these myths persist? Well, anybody who's heard of TikTok we can stop the conversation right there. It's like TikTok and those things are the reason that these persist. Everybody has an opinion, and there's a lot of social media on nutrition because everybody's an expert, but they're really not. So, I really wanted to kind of bring in a lot of that. The other challenge we have is with any scientific research, there will be non-responders. There will be people who are opposite responders. A lot of things depend on your genetics. So 50% of diet is genetics related, and the other 50% is what you're actually doing every day. So while we are guiding the science and we're doing the uh, reviews in the literature, also know that there were people who will respond differently depending on their ethnicity, their genetic background. So we're going to take a lot of this with a grain of salt, but also kind of just show that there are a lot of things that are just, this is the best practice for most individuals. Next slide, please. So with content, these are the things we're going to go over. You can see it's quite a bit, and a lot of it's some really fun ideas here. Next slide, please. Okay, so we're going to start off the bat with apple cider vinegar. This is one that I really was like, this is pseudoscience until I looked into it. I will tell you it is not a magic bullet, and every single one of these control trials were done with physical activity and a caloric reduction. So we're talking 500 to 750 calories per day reduction. However, we did notice that if the person took for 12 weeks 30 milliliters of apple cider vinegar every single day, there was an average weight loss of about 16 pounds at the end of 3 months. Now, that is mindful and that is very helpful, but there is a lot of information around that where essentially this is a very challenging thing to do. And if you ask someone to drink 30 milliliters or a shot glass full of apple cider vinegar every day mixed with water, that is a very challenging thing to do, especially for 3 months. So while the literature does state that this is a possibility, it is very, I don't know. I don't know how to phrase this. I even tried this myself just to see what it tasted like, and it's really, really challenging to consider doing this for 3 months. So take it for what you will. The effect is modest. For some people, it could be helpful. There is no noted challenges with this. However, if a patient has gastroparesis, you really need to be mindful because there is a decrease in gastric emptying with the vinegar. And so if they're also on mealtime insulin, they may have a slight risk of hypoglycemia. So that is that is the research. And the P-score was well over 0.01. So they found that it was a potential. Um, do not have your patients, if they want to try this, do not drink this straight. It will burn the throat. You have to rinse your mouth out with water. Okay. Yes. If they have any kind of GI concerns, you definitely want to just maybe avoid this concept. But I'm just presenting from the case of diabetes and overweight what was noted. But um, yeah, there you have it. Okay, next slide, please. So resistant starch is the next fun one. Resistant starch is naturally occurring in a lot of foods. You can see it in things like green bananas, beans, root vegetables, different grains, so breads. The popular concept around this is that if you cook a potato or a grain and then you stick it into the refrigerator and then you eat it tomorrow, it will have had time to build up a higher level of resistant starch based on the cooking and cooling process, which will then increase the dietary fiber and reduce the amount of glucose that the person can get from that food, glucose or starch, just total glucose. There are not enough high quality randomized control trials to state that this is fact. So my recommendation is that patients can try it with foods that they are already eating. So if someone is already going to eat a half of a baked potato, try try it with a glucose sensor and try to consume that tomorrow and see if it truly does lower your glucose for that 30 grams of potato. But it's truly not verified in science that this will work for everyone. Okay, next slide, please. Okay, I threw in some memes because I think memes make things funnier. So, um, fruit is bad for diabetes, and that verdict is actually false. We truly want to have patients eating whole fruit. That's the big part there is fruit that is whole, not so much the applesauce or the canned fruit or apple juice or other juices. Despite the fact that it is a helpful food, we do want to be mindful about the portion sizes. Total carbohydrates do matter, especially when a patient is taking insulin or they're trying to be mindful about their weight loss. So I threw over here something I made with AI that is just 15 grams of carbohydrate per portion. The small banana is a little bit higher. It's about 20 grams of carbohydrate, but you can see where fruits do fit and being mindful about encouraging them to have those fruits. Those are really great sources of natural vitamins and minerals. So just please, don't tell your patients not to eat fruit, but just be really mindful about the portions. Fruits can fit within a healthy diabetes diet. Next slide, please. Okay, so protein. Should we just eat it no matter the source? I don't know if everyone's older than me or remembers Weird Al's Eat It, but I thought that was pretty funny. So here we go. You're going to get this every single time, but whole food is really where we want to go with our patients with diabetes. In the literature, they found that those high protein processed foods were considered, and I'm doing air quotes, somewhat healthier than regular. So if they were going to consume cereals or chips or crackers, if they have higher protein, then generally they are lower in caloric value, lower in total sugars, lower in carbohydrates. You can see the HP is a high protein food, where the NP is a normal protein food. And the more the green, the higher the quality of the food or the nutrition score. They also had higher fiber in those higher protein foods. Please be mindful that no matter what it is a processed food. You're going to have higher levels of sodium content, and that is very important, especially for patients who have comorbidities such as hypertension or coronary artery disease. It's still a processed food, and we need to be mindful about sodium intake. Bottom line, no matter what, is your chicken breast, your fish, your beans, those are all more nutritious than anything you're going to buy in a box. So please, take all of this with to be a grain of salt, but not, I did not mean that to be sick, kind of silly that way, but truly let's be mindful about higher quality foods. Next slide, please. Okay, this one's really big right now. So artificial sweeteners. I threw all of the different literature reviews just so you could see the conclusions and what they had to say. And you can see that a lot of the information out there really talks about, well, we don't see any elevation in blood glucose. We don't see any challenges with weight gain. It does not seem to increase the appetite or to increase food intake. And let's see, it appears to be helpful for blood glucose stabilization. So you all will have access to the slides, and all of the literature is at the end with the DOI. So it's a quick link. You can link to all of them. I'll go ahead and switch over to that next slide. And it'll just talk a little bit more about artificial sweeteners. I figured it'd be helpful for you all to see the differences. So there's nutritive and non-nutritive. Non-nutritive are the ones that absolutely do not have any caloric value. And they are more of your stevias, your truvias, your splendas, sweet and lows, equals, aspartame, all those things. Monk fruit as well. When you get into nutritive, it's sugars and sugar alcohols. Sugars, as you know, have caloric value. They are glucose. For sugar alcohols, you will have those things that end in an "-all". It's not alcohol, but it's just the formation of the shape. And so sugar alcohols do, in some cases, increase blood glucose, but it's very minor in the amounts that most people will eat. And I'm going to say most people. There's a chance that people might eat a lot of these items, especially those sugar-free chocolates and things like that, have a lot of mannitol or maltitol, sorry, maltitol, and that can increase blood sugar to some effect. With everything out there, it does state that the non-nutritive does not raise blood glucose. The sugar alcohols can very minutely raise the blood glucose. It does not appear to help significantly with weight loss if a patient chooses to have these, but it doesn't seem to cause the weight to go up. So it's kind of a net neutral. Long-term outcomes continue to be studied, and we still need, and you're going to see this on every research study, we still need more high quality research studies to truly know what happens long-term when people eat these. So my recommendation is please just use with moderation if you're going to consume these. Um, the one thing with the Coca-Cola study that everyone's probably itching to hear about, that was a one country study in Argentina, and it was a longitudinal study. So it wasn't actual true research. I'd just be mindful about, not trying to make your entire diet Coke, and really being mindful about not consuming too much of these things because they really are just kind of an every now and again thing. Next slide, please. Are natural sugars healthier? So technically, the research shows that yes, they are slightly healthier to have things like the honey or the agave nectar or the maple syrup. However, they are still not, they're going to raise your blood sugar, and they're going to raise your blood sugar to the exact same effect that table sugar will. So just being mindful about that. If someone's trying to put honey in their tea and say, well, it's healthier for me, that doesn't mean that we need to consume a ton of it. The best thing to do is also to avoid or super limit sugar sweetened beverages because the human body does not equate that to true calories. And so that sugar will just go in and it will be absorbed. And it's very easy for the person to consume a ton of extra sugar in their diet without really feeling it or realizing it. With all of these things, please consider the portion sizes of this. And I did throw that out there so that you all could see, made that slide with AI as well, just the 15-gram carbohydrate view. So you could, plan around that. So next slide, please. This is the tier list, again, made with AI, but just avoiding refined sugars, minimally processed natural sugars is a better option, but still caloric and still will raise blood sugar. Your whole fruits are your best bet because A, you're getting fiber, you're getting nutrients, and you're getting a dense nutrient package that will slow down digestion. Okay, next slide, please. Does sugar-free equal carbohydrate-free? Technically, most of the time, no. I marked off all of the labels. Unfortunately, you can probably still tell exactly what these are, but doing my best here to keep it friendly. So essentially, your patients do need to look at the nutrition label, not just the really fancy sugar-free on the front of the package. You can see there for the chocolates, 2 pieces of chocolate in the center, no sugars, but it is 17 grams of carbohydrate, 15 of those being sugar alcohols. For the vanilla pudding, I had to throw it to the side because it's too hard to see, but a half cup prepared with the milk would end up being 11 grams of carbohydrate. And for one of those sugar-free cookies, it's 13 grams of carbohydrate, 6 of those being maltitol, which will still affect blood glucose to some degree. So please have your patients look at the serving size, look at the total carbohydrates, and then look at, the sugar grams overall when they're planning for these. These are sometimes foods, maybe, like these are treats, but just being mindful that to some degree it can affect the blood sugar. Okay, next slide, please. Okay, this is a big one. Time restricted eating. Um, in general, this does improve metabolic outcomes. If someone wants to do time-restricted eating, it will require a medication adjustment if they are on some form of insulin. It does improve the A1C. It is modest but consistent. Um, it helps improve the glycemic stability, and it is clinically feasible to do this time restricted eating. So kind of coming up with a window and then planning the basal insulin around it. If they are on basal insulin, a lot of times they'll need an increase in basal and a decrease in their short-acting insulins for the meals. Um, but overall, we've seen a pretty good improvement. And generally, we just kind of recommend if patients want to do this to start off with the 12 window. So 12 and 12, eating for 12 hours and fasting for 12 hours. A lot of people can do that, and that's very minor for medication adjustment. Okay, next slide, please. Okay, so the head-to-head vegan, vegetarian diets versus low-carb diets. And I'm not going to say you can see, but essentially, it does show that if a person's eating a vegan diet or a low carb diet, they do have improvements in their A1C and their body mass. Low carb diets tended to have a higher increase in HDL and a more reduction in triglycerides and lower blood pressure when they ate a low carb diet. Um, for vegetarian vegan diets, it needed to be at least 12 weeks for them to see an improvement. And let's see, the other thing was there was no significant improvement in fasting plasma glucose, so fasting blood sugar in the morning with the vegan vegetarian diet. Overall, I really wanted to showcase this as there are multiple ways to eat healthy. All of it has to stem from eating whole foods, though. So this is not eating trash, and this is truly eating like whole foods. Um, but next slide, please. You'll see that okay, um, the ADA showcases that they feel that lots of opportunities are available for patients who want to truly lose weight, but it all comes down to losing 500 to 750 calories a day as an energy deficit. So for women, this tends to be about 1,200 to 1,500 calories. For men, about 1,500 to 1,800 calories. Please take that for the information that it is highly variable depending on how they started. So someone might be eating two 2,500 calories just to maintain their body weight. You're going to have to slowly work them down. Um, so some RCTs report that less than 5% of weight loss can start to slowly improve their metabolic case, but it truly ends up being about 7, 10, or 15% of their weight loss is where you're truly going to get that benefit for all things. So that's an important feature as well. Let me see. And very important, 8.9 shows it needs to be individualized to the patient's preferences. So if you're going to try to have someone do low carb and they're very against that, that's not going to work. You kind of go more, it's like, well, what do you want to do? Do you want to do more of a Mediterranean focused? Are you really interested in plant-based? And kind of working with them to find where they're more interested in making that calorie deficit. Next slide, please. So low carb, all of them are there. The ADA recognizes multiple healthy eating patterns. Eating whole foods is important. Consistency matters significantly for weight loss. And finding out what that patient is going to stick with. This is where we at Humphrey Center like to put a CGM on the patient and help them find their personal carb balance. Maybe that person does well with 30 grams of carbohydrate at meals, irrespective of what focus pattern. We're just kind of, okay, what does 30 grams look like for you and your blood glucose? Some people can get away with 50. It really just depends on the person. Next slide, please. So CGMs and nutrition, this is again just kind of capitalizing on that. We already had a really big, wonderful conversation on CGMs, but avoiding overacting to single glucose excursions. So if a blood glucose goes really high after a certain food, be your own scientist. Figure out, well, why did it do that? Can I adjust the portion of that food? Checking blood glucoses before meals and 1 to 2 hours post-meal can also help you understand your personal carb tolerance. In general, we recommend that the 2 hour after meals is under 180. Under 160 is even better, but that can help the person understand like what their carbohydrate balance should be for those meals. Next slide, please. Does everyone need to take a multivitamin? The ADA says no. I would say if you have a patient who is trying for weight loss, that is an important thing to do. Is like, and it doesn't have to be every day. It could be every other day or every 2 days. But if they're consistently consuming less than 1,200 calories, if they are doing something low carb or they are being strict vegetarians, they are going to miss out on some nutrients. If you have people who are over the age of 50 and are having any kind of health conditions that impair nutrient absorption, that's another piece where you need to work on kind of looking at what other supplements they could take. The multivitamin was the only one that the ADA had anything to say on. For supplements specifically, they're like, we don't have enough research to truly believe that any kind of supplement is beneficial for a patient. So they don't have a statement for that. Okay. Um, yes, thank you. So GLPs, we do not want to focus on just losing weight with GLPs. This is a big problem. So ensuring that if you have patients who are using GLPs for weight loss, that they are capitalizing on protein first meals because they are going to lose their appetite, with some cases very rapidly. So eating their protein first at meals. I did throw out some practical daily goals with GLP therapy, but essentially, I know a lot of patients are not going to look at 1.6 grams of protein per kilogram per day. So just looking at it from a practical is for females aiming for like 80 to 120. For males, they could up that somewhat. Um, and then my personal goal is aim for at least 20 grams of protein per meal. If they're eating only 2 meals, then they really need to up that probably to 30, 30, maybe 40. But that 30 is a really great range for most patients for each meal. Okay. Um, Next slide, please. Thank you. So this is just some portion sizes. I left the eggs on there, although that is an insane amount of eggs for any person to eat, but it's to showcase that if you have that patient that says, well, I'll eat one egg and a slice of toast for breakfast, well, they basically got maybe 8 grams of protein. So we're really like lowballing that. So looking at like what they're eating and talking to them about that. 1.5 cups of Greek yogurt, if anyone's ever tried to eat that much in one sitting, is an insane amount of yogurt. So most times they're about a half cup portion. So just looking at what they're constantly eating and then going, okay, well, how can we increase that? So you'll see that the animal-based will have more protein per ounce versus the plant-based, but still I believe that animal and plant-based have a lot of room to coincide within a natural healthy diet. Okay, next slide, please. I've heard this before is never eat white foods, but we should probably be saying more along the lines of, try to um, choose whole grains, brown rice over white rice, whole wheat bread over the regular enriched white grain. There are a lot of really great white foods that are truly nutritious, and sometimes patients will take what a provider says to heart and they'll absolutely follow it stringently. And it's like, oh, I omitted everything that was white in my kitchen. So it's like kind of difficult sometimes. It's like when you say lower sugar, so they take their sugar from the top shelf and put it on the bottom shelf, and they technically lowered their sugar. So, okay. Next slide, please. So key points, in summary, there is no single diabetes diet recognized by the ADA. Um, Multiple opportunities are there for patients to eat healthy. It really is important to eat whole foods, have protein and healthy fiber, and to have sustainable habits, not trendy diets, but to eat something and eat in a way that you can continue to eat every day. Individualize that for every patient and they'll do well. Next slide, please. There's all of your references if you want to read on that. And that's my presentation.
Great. Rachel, thank you so much. That was fascinating. And we've got great questions in the chat. So I'm just going to go through them. Really appreciate your presentation. Okay, so from Marisa, she said, my understanding of the resistant starches is that once it's been cooked, then cooled, it can be reheated and then the resistant starches remain. Can you please correct me if you know otherwise?
That is correct. Like you do not have to eat it cold to have the resistant starches in there. The resistant starches will remain after the heating again process.
So no ethical concerns, Matt. Okay, Lisa was asking about what is your opinion of Reb M? I'm seeing it in several protein shakes.
Oh, Rev M? I'm not familiar.
Maybe, Lisa, do you want to unmute and explain what you've been seeing in the protein shakes? It was REBM.
Sorry. Uh,
Oh,
I found it. Yeah, it's this stevia based um, sweetener. What I looked up, it's like 300 times sweeter than sugar. And so I was just curious if you guys had seen any of that affecting diabetic patients or glucose levels.
With a stevia derivative, if it's not applied to a erythritol, there won't be any blood sugar increase or any carbohydrates because it's a non-nutritive. So it's a lot of times though that it can be. So I'd have to look that up to be 100% sure.
Okay, that'd be
Yeah,
great.
yep,
Thank
I
you.
can definitely, absolutely.
it sounds like Sarah was adding a little more information there too. So stevia is naturally bitter, so they extract the sweet part only. That's what they get. That's super sweet. Okay, thank you. We had another question then from Amy. So on the time restricted eating, is it recommended for patients to eat one large meal or smaller meals over the 8 to 12-hour eating window?
Typically, we're recommending more smaller meals. So if they're really restricting, like if you're eating in a 12 hour, then you have room for 3 meals, right? If you're eating in less than that, which I really think you should be working with your provider and probably a dietitian, but if you're eating less than that, then we could go into 2 meals. There are some people who do well with a 1 meal per day, but that's incredibly challenging for most patients. And that causes a lot of challenges with just nutrition in general for someone to be able to get what they need in a day in 1 meal nutritionally is very challenging. So I typically don't recommend 1 meal, 2 at the least, but preferably 3 meals, but just smaller density.
Okay, and then another just rapid fire questions here. Thank you from Sarah. Was the vegan diet improvements due to higher fiber intake?
Generally, yes. And you know that that's mostly whole food. And so higher fiber, a lot of times it's in the area of like 40 to 50 grams of fiber per day, which is a lot. Um, and that definitely helps improve with the cholesterol and fullness, obviously, because that's it's a lot of dense nutrient matter.
Great, thank you so much. And then the last question, Brian, I'm going to ask you to unmute so that I don't mispronounce anything. Would you ask your question of Rachel, and then we're going to wrap up our Q&A and transition to our case today.
So vitamin B8, also known as inositol, as well as berberine with cinnamon. Thoughts on that for insulin resistance and hyperlipidemia?
Okay, so I will have to look up the inositol because I'm not as familiar with that, but I can tell you that in a head-to-head, berberine appeared to act similar to metformin, and it helped improve both lipid profiles and glucose. So they saw A1C reduction with berberine. And I've had a handful of patients who have tried that because they refused to use metformin. They did have improvements in their A1C.
Yeah, because we got lots of California granola crunchers out there that if it comes from a pharmacy, they won't do it. But if you can get it online from a herbal store, they'll take it no matter what it is.
I hear you.
So yeah,
Let me owe you that one on the inositol, but I had when I went to the ADA conference, they actually talked about berberine and the improvements in the lipid profile and the A1C. So berberine appears to be helpful in some cases, and it could
yeah,
be a patient case by case basis as well.
yeah. I've seen some data on cinnamon dropping down. If you get the right kind, I think it's cinnamon Ceylon, you get like a half point drop on A1C. So there's some products on Amazon that'll pair berberine with cinnamon inside a single capsule. So those are nice.
Nice.